Hello everyone and welcome to our module on lumbar radiculopathy. The word radiculopathy refers to compression of a nerve root at the spine. So when we say a lumbar radiculopathy, we are talking about a radiculopathy that occurs in the lumbar spine. You can also have radiculopathies that occur in other places like the cervical spine, but the lumbar spine is especially common because this is a site of bending and weight bearing, and therefore a lot of nerve root problems occur here. And there are many causes of lumbar radiculopathy, but some of them are listed on the slide here. These include a herniated disc, which we'll talk about in a minute, also spondylolisthesis, and also spinal stenosis. All of these things can lead to a lumbar radiculopathy. So I'm going to start by talking about the causes of lumbar radiculopathy. In other words, processes that can lead to compression of a nerve root in the spine in the lumbar region. And the first cause is a herniated disc. So in order to understand this, let's review what the intervertebral discs are in the spine. These discs serve as a cushion between vertebrae. One is shown on the screen here. It's the blue thing in the middle. They consist of an outer fibrous ring, which is called the annulus fibrosus, and then there is a soft center, which is called the nucleus pulposus. If an intervertebral disc herniates, that can cause compression of a nerve root, and this is the most common cause of a radiculopathy. This happens when there is degeneration of the annulus fibrosus. That leads to bulging or extrusion of the nucleus pulposus, and that can compress a nerve. It usually does this only on one side, so you get unilateral nerve compression. So for example, if you look at this picture on the bottom left side of the screen here, you can see that the intervertebral disc has herniated towards the back and it's compressing the spinal root on one side of the spinal canal. There's also a picture on the right side of the screen showing you how this commonly occurs in the lumbar spine region and leads to what people commonly refer to as a pinched nerve. Herniation of an intervertebral disc often occurs posteriorly. If you look at this drawing on the bottom left side of the screen here, this is the front of the body and this is the back, and the disc is drawn herniating towards the back, and that's the way it commonly happens in reality. The reason for this is because there is a ligament called the posterior longitudinal ligament that is relatively weak and often leads to posterior herniation. It's very high yield to understand this for step one of your boards. There are two ligaments that contain the intervertebral discs in the spine. One is called the anterior longitudinal ligament, and the other one is called the posterior longitudinal ligament. They're both shown in this drawing on the bottom right side of the screen here. This is the spine here, this is the posterior ligament, and this is the anterior ligament here. The posterior ligament sits within the spinal canal as shown in the drawing, and it covers the posterior surface of the vertebrae, and it is relatively weak compared to the anterior ligament. Therefore, when these discs herniate, they often do so posteriorly, and that leads to unilateral nerve compression like shown in the drawing. Herniated discs are one of the most common causes of radiculopathy, but there are many other causes. One of these is spondylolisthesis. This means forward displacement of one vertebrae over another. The word spondylo means vertebra or spine, and listhesis means movement. So a spondylolisthesis means a movement of the spine. A related term is spondylosis. This term is used to just mean degeneration of the spinal column. But when the spinal column degenerates in elderly people, that often leads to spondylolisthesis, and that's why I'm defining these two words for you now so you don't get confused. And when there is slippage of one vertebrae over another in a spondylolisthesis, this can cause a radiculopathy. And the final cause of radiculopathy that we're going to discuss in this video is spinal stenosis. Spinal stenosis, as the name implies, means narrowing of the spinal canal. This is usually an age-related condition. It's much more common among the elderly. And the reason this occurs is because as we age, the intervertebral discs shrink. They lose their fluid content. And when they do so, this narrows the foramen through which the nerves exit the spinal canal. In addition, as the intervertebral discs shrink, the facet joints in the spine rub against each other, and this leads to arthritis, which can lead to the development of facet joint bone spurs, and those can also impact the nerves as they exit the spinal canal. And then finally, there's a ligament in the spine, I'll show you a picture of this in a second, called the ligamentum flavum, and this hypertrophies because of the extra strain on this ligament. So the facet joint arthritis and the ligamentum flavum hypertrophy are kind of buzzwords for the processes that go on when the spinal canal undergoes spinal stenosis. So all of these things, the shrinking of the disc, the facet joints, the ligamentum flavum, it all leads to nerve root compression, and this leads to a radiculopathy. And one thing you always want to remember about spinal stenosis that makes it easy to recognize clinically and in a board question is that when you stand up and straighten your spine, this normally narrows the lumbar canal. So this makes symptoms worse in a patient who has spinal stenosis. These patients will prefer to be bent forward. That makes them feel better. Shown on the left side of the screen is a zoomed in picture of the facet joints. The bones in these joints can rub up against each other in spinal stenosis. That can lead to formation of bone spurs, which can lead to radiculopathy. On the right side of the screen is a cross section through the spinal canal. This is the ligamentum flavum, and as the intervertebral discs shrink with age, stress is placed on the ligamentum flavum. It can undergo hypertrophy, and that can further narrow the pathway for spinal roots to get out of the spinal canal, and that can contribute to the radiculopathy and spinal stenosis. Spinal stenosis causes a symptom known as neurogenic claudication. This is leg pain with walking that occurs in spinal stenosis, and it can mimic vascular claudication. So patients who have peripheral vascular disease and poor blood flow to their legs will also get pain with walking. That is called vascular claudication. The claudication that occurs in spinal stenosis is called neurogenic claudication. There are some features that are useful for distinguishing neurogenic claudication from vascular claudication. So in neurogenic claudication from spinal stenosis, the pain in the legs often persists even with rest, especially if the patient is standing, and the pain will improve when they stoop or flex their posture, as I told you on the last slide. So when you're taking the history of someone with pain in the legs and trying to determine whether it's from vascular disease or spinal disease, these types of features of the pain are very important. Shown on this slide is a drawing of the lumbosacral plexus, and this drawing shows the nerve roots that are involved in lumbar radiculopathies. For example, the fifth lumbar nerve root is one of the most common nerve roots to develop a lumbar radiculopathy. But what I want to point out to you here is that many of the nerve roots in the lumbosacral spine contribute to the sciatic nerve. It's the largest nerve in the body, and it derives from nerve roots from L4 all the way down to S3. So if you have a radiculopathy involving any of these nerve roots here, that can lead to problems in the sciatic nerve. So before we get into specific nerve root radiculopathies, let's talk about the sciatic nerve. As I said before, the sciatic nerve is the largest nerve in the body. It's up to 2 centimeters in width. Behind the knee, it branches into the common peroneal and tibial nerves. That's shown in this drawing here. The sciatic nerve runs down the back of the leg, and then behind the knee, it branches to become the tibial and common peroneal nerves, which supply the lower leg and foot. Functions of the sciatic nerve include certain motor functions. It's motor to muscles of the posterior thigh and the hamstring portion of the adductor magnus. I'll talk more about this in a minute. And then it gives off branches that supply the muscles of the leg and foot. In terms of sensory functions, the sciatic nerve has no direct sensory functions, but it gives off lots of branches that are sensory to the skin of the lateral leg and the heel and the foot. The easiest way to remember the motor functions of the sciatic nerve is to just remember that it innervates the hamstring muscles, and then if you know what the hamstrings do, you can answer questions about the sciatic nerve. The hamstrings are 3 muscles, all found in the posterior thigh. The first one is called the semimembranosus. This is the most medial hamstring. The semitendinosus is in the middle, and the biceps femoris is the most lateral hamstring. In addition, there is a 4th muscle that is not a hamstring, but it functions just like a hamstring. That's called the adductor magnus. If you look at this picture on the screen here, this is the adductor magnus. It's this muscle here. It has 2 portions. It's a medial thigh muscle with 2 portions, and one of the portions is called a hamstring portion, and that works just like the hamstrings. So basically, these 4 muscles all do the same thing. You can just think of them as the hamstring functions, and the major function of the hamstrings are to flex the knee and extend the hip. Also, they do a little bit of hip rotation, but most importantly, they flex the knee and extend the hip, and all these functions depend on the sciatic nerve. Some of you may know of the condition referred to as sciatica. This is the name given to a clinical syndrome with many causes, and the term is often used to describe the pain of lumbar radiculopathy that involves the sciatic nerve. So patients who have low back pain that radiates along the path of the sciatic nerve are often said to have sciatica. This means pain that goes from the low back to the buttocks to the back of the thigh. This is the path of the sciatic nerve. This is commonly caused by a herniated disc, which can compress one of those nerve roots that feeds fibers to the sciatic nerve, and this leads to inflammation, pain, and numbness in the affected leg, and that's what causes the pain symptoms of sciatica. Let me go back to this slide and clear up a point of confusion. The sciatic nerve derives from nerve roots from many spinal levels, starting at L4 all the way down to S3. What this means is that a herniated disc cannot knock out your entire sciatic nerve. Patients can get the clinical syndrome of sciatica from a herniated disc, meaning they can develop pain traveling along the path of the sciatic nerve, but you can't lose your whole sciatic nerve from a herniated disc because the sciatic nerve comes from multiple nerve root levels. In order to lose your whole sciatic nerve, you need to have a lesion somewhere beyond the spinal canal after the point where all these nerve fibers have come together. To get a complete sciatic neuropathy, and one thing that commonly does this is problems with the hip. So a hip fracture or dislocation can cause sciatic neuropathy. This is because the sciatic nerve runs behind the hip joint, and posterior hip dislocations are the most common type of hip dislocations, and those can lead to a sciatic neuropathy. You can also see this following hip replacement surgery. Another cause of sciatic neuropathy is prolonged compression of the buttocks and the back of the leg. This can happen to people who are in a coma or on long-term bed rest. It's also sometimes seen in alcoholics who pass out on the toilet seat and compress their sciatic nerve and develop a sciatic neuropathy. Now, if the neuropathy is mild, it may just cause sensory problems like pain and paresthesias, but if it's severe, patients can develop hamstring muscle weakness. And what they will complain about in that case is foot drop. They will lose dorsiflexion of the foot and their foot will be dropped forward. This is what happens when you lose the common peroneal nerve, which, as I said before, is a branch of the sciatic nerve. And then, as I mentioned before, you can also have sensory problems if the sciatic nerve is disrupted. Patients often complain of sensory loss in the lower leg or foot. Now that we've talked about the sciatic nerve, let's talk about symptoms that develop when specific nerve roots are compressed. So when a herniated disc develops, it tends to compress the nerve root below the disc. So for example, if the disc between L4 and L5 herniates, it tends to compress the L5 nerve root, not the L4 nerve root. And the most common nerve root to be compressed from a herniated disc is L5. The second most common is the first sacral. Herniated discs at these levels are often diagnosed by imaging, but there are some symptoms that are classic for particular nerve roots, so let's go over those now. So nerve root L5 is the most common radiculopathy syndrome. This occurs when there is a herniated disc at the L4-L5 vertebrae. This will lead to pain going down the lateral leg, and you can remember that the L in L5 stands for lateral to remind you that this nerve root delivers fibers to the lateral leg. In addition, this nerve root delivers fibers that are important for foot dorsiflexion and toe extension. Shown on the screen here is a foot being plantar flexed and dorsiflexed. So dorsiflexed means to pull the toes up towards the knee. Patients who have an L5 nerve root radiculopathy will not be able to dorsiflex. Therefore, they will have difficulty walking on heels if you ask them to do this in the clinic. And the reason for this is because many of the nerve root L5 fibers go on to supply the common peroneal nerve, and the common peroneal nerve is what innervates the muscles of dorsiflexion in the foot. Compression of the S1 nerve root is the second most common lumbar radiculopathy syndrome. This happens when there is herniation of the L5 to S1 disc. This leads to pain that radiates down the back of the leg in contrast to pain on the lateral leg for an L5 lesion. And also in contrast to L5 lesions, S1 lesions lead to weakness of plantar flexion, not dorsiflexion. This means the patient will have difficulty standing on their toes. It also means the ankle reflex will be lost. In the ankle reflex, you tap on the back of the ankle with a reflex hammer, and that causes the patient to plantar flex. This will be weakened or lost if there is an S1 nerve root lesion. And the reason this is the case is because many of the S1 nerve fibers supply the tibial nerve, and that's what innervates the muscles of the foot responsible for plantar flexion. L5 and S1 are the most common radiculopathy syndromes, but there are more rare radiculopathy syndromes that involve nerve roots higher in the lumbar spine, like L2, L3, and L4. And an easy way to remember the symptoms of these radiculopathy syndromes is that just like they are higher nerve roots, they tend to cause symptoms that are higher in the leg, such as symptoms in the thigh or knee. And if you've watched the video on the lumbosacral plexus, in that video I talk about how the femoral nerve derives from all of these nerve roots. So many of these symptoms are related to dysfunction of the femoral nerve. So there can be pain in the anterior thigh and knee. There can be weakness of hip flexion and knee extension. These are all actions carried out by muscles innervated by the femoral nerve. And then finally, you may see a reduced or absent knee or patellar reflex. This reflex is elicited through the femoral nerve, and therefore if one of these nerve roots is impacted, that can lead to a decreased patellar reflex. I'll finish this video with one slide on the straight leg raise test. This is a very common bedside maneuver performed to test for lumbar radiculopathy. So for example, if a patient comes to clinic and complains of right-sided back pain and pain going down the right leg, the examiner will ask the patient to lie on the table as shown in this drawing here, and then the examiner will raise the extended leg on the symptomatic side up to 90 degrees just like shown in this picture. What this does is stretch the sciatic nerve and also the nerve roots, and if the patient has a lumbar radiculopathy, this will lead to worsening pain on the affected side. This is called Lassig's sign. And the straight leg test is a very commonly performed test when you're working up a patient for back or leg pain and you suspect a lumbar radiculopathy. And that concludes our video on lumbar radiculopathy.